Welcome to This Explainer. If you're a med student or a resident stepping onto the urology ward, or maybe grinding it out in the outpatient department, listen up because this one is absolutely for you. Today, we're breaking down the crucial framework for diagnosing and managing scrotal swellings. The acute scrotum is this massive clinical spectrum. You've got everything from completely benign fluid collections right up to surgical emergencies that literally count down by the minute and even aggressive malignancies. By the end of our time together, you are going to have a systematic, foolproof guide for your OPD assessments. Okay, let's jump right in.
Picture this. You're on call. It's 2 in the morning. A 19-year-old college athlete comes into the ED with sudden, exquisite left testicular pain that actually woke him out of a dead sleep. On your exam, the testicle is lying horizontally, it's retracted high, and the cremasteric reflex? Totally absent. Now, as the junior doctor on duty, your first instinct might be to just, be thorough. So do you play it safe and order a Doppler ultrasound to confirm your diagnosis before you go and wake up the surgical attending?
The answer is an absolute, definitive no. Seriously, don't do it. This brilliantly illustrates what we call the board and OR trap. The guidelines clearly warn us about this. Delaying surgical exploration for an imaging scan in a high-probability torsion case is actually the #1 cause of testicular loss. And, as you might guess, it's the #1 cause of medical legal claims in these cases too. If your clinical suspicion is high, that patient belongs in the operating room immediately.
So, here is our roadmap for today's explainer. We'll start with pearl and oyster anatomy, move into the clinical diagnostic matrix, run through a step-by-step physical exam, look at master management protocols, and wrap up with some golden bedside pearls.
All right, Section 1, Pearl and Oyster Anatomy.
To really nail an acute scrotum diagnosis, you need a solid mental model so you can visualize exactly what you're palpating beneath the skin. I want you to think of the testicle as a precious pearl, and it's suspended inside a fluid-lined shell. That's the tunica vaginalis. This analogy just makes the pathology so much clearer. A hydrocele simply expands that shell casing with excess fluid, but the pearl itself is totally fine. A varicocele? That means the internal plumbing, the venous plexus surrounding the cord, is overheated and dilated. Torsion means the supporting chain is twisted on itself, completely cutting off the power supply. And testicular cancer? Well, that's a solid intrinsic flaw growing directly within the matrix of the pearl itself.
Now, why does torsion even happen in the first place? It's usually caused by this fascinating anatomical quirk known as the bell clapper deformity. Normally, the tunica vaginalis attaches securely to the back, holding the testicle in place. But here, that posterior attachment completely fails. The testis is just freely suspended, swinging around like a clapper in a bell. And that allows it to freely rotate right around the spermatic cord axis. This sets off a brutal, rapid cascade: venous occlusion, then progressive edema, arterial compromise, and ultimately irreversible hemorrhagic necrosis of those germ cells, all within just 6 hours. The clock is quite literally ticking.
Moving right along to Section 2, the clinical diagnostic matrix.
Now that we've got our anatomical blueprint securely in mind, let's pivot to targeted history taking. Honestly, the questions you ask in those first 2 minutes, they heavily dictate your entire pathway. The timing of symptom onset is your very first major clue. Torsion strikes suddenly. It's hyperacute, often waking a guy from sleep, usually with some nausea and vomiting thrown in. Epididymitis, on the flip side, builds in a slow, gradual crescendo over a few days. Oh, and if the enlargement is completely painless, your mind should immediately jump straight to cancer or a hydrocele.
You really have to systematically interrogate the history here. Ask about lower urinary tract symptoms, dysuria, or fever, because those scream epididyma or chitis. Ask about systemic red flags like weight loss, back pain, or gynecomastia, which could point to a metastatic germ cell tumor. Note any prior surgeries, like a hernia repair. And finally, ask if they feel a dragging sensation or a heaviness that gets noticeably worse when they stand up. That perfectly describes a varicocele.
Okay, quick detour, and this is a really high-stakes one for you on the ward. We know most varicoceles are on the left side, just because of normal human anatomy. But what if a patient presents with a brand new, non-reducible varicocele specifically on the right side? Why does that one specific clinical finding trigger an automatic, mandatory CT scan of the abdomen?
Well, it all comes back to the plumbing. The left testicular vein enters the left renal vein at a 90-degree angle under a lower pressure system. But the right testicular vein, it drains straight and obliquely right into the inferior vena cava. So if you've got a new blockage there, it strongly suggests there is a retroperitoneal mass obstructing that venous return. The absolute textbook nightmare you are looking to rule out here is a renal cell carcinoma tumor thrombus that's extended right into the IVC.
All right, Section 3, Step-by-Step Physical Exam. When you're at the bedside, this isn't just about randomly feeling for a lump. You are conducting a strict binary rule-out sequence. Follow these exact 4 steps every single time. First, grab a narrow light source, turn down the room lights, and do transillumination. A red glow means you've got clear fluid, like a hydrocele. Opaque means you're dealing with a solid tumor or maybe thick blood. Second, palpate the top of the swelling. If you can get your fingers above it, it's an intrascrotal lesion. If you can't get above it, you're probably looking at an inguinoscrotal hernia coming down from the abdomen. Third, physically elevate the scrotum. If that actually makes the pain better, that's a positive Prinz sign, which points to epididymitis, because you're easing the traction from gravity. If it doesn't relieve the pain, you better suspect torsion.
And finally, step 4, the cremasteric reflex. By lightly stroking the upper inner thigh, you are testing that L1, L2 sensory reflex. Honestly, this is a massive game changer on the ward. A preserved reflex has a remarkably high negative predictive value, meaning it essentially rules out typical torsion. An absent reflex, however, that is strongly diagnostic for testicular torsion.
Which brings us to Section 4, Master Management Protocols.
So you've synthesized the history, you've done the exam. What is the final verdict? How do we actually manage these based on international protocols? This gold standard matrix right here aggregates all the definitive pathways for you. It's a great reminder that torsion demands immediate surgery, a scrotal exploration, detorsion, and bilateral orchidopexy, all within that strict 6-hour window. Epididymitis, where you have a positive Prinz sign and an intact reflex, is managed medically with antibiotics like ceftriaxone and doxycycline. Cancer, that requires a radical orchiectomy. And a benign hydrocele can just be observed, or maybe surgically plicated down the line if it gets too burdensome for the patient.
Let's look a little closer at what the top-tier societies are saying. When you compare the European Association of Urology and the American Urological Association guidelines, their overarching universal message is crystal clear. Never, ever let a Doppler ultrasound delay the operating room if you suspect torsion. Furthermore, if you're dealing with a solid intratesticular mass, drawing preoperative tumor markers, specifically AFP, beta-HCG, and LDH, is absolutely mandatory across the board. And the surgical approach for those masses must always be inguinal, never transscrotal.
And you know, those tumor markers are critical for a reason. As the AJCC TNM criteria brilliantly illustrate, staging testicular cancer relies heavily on them. The TNM criteria stratify these patients not just by the anatomical extent of the tumor, like whether it's invading the spermatic cord or the scrotum, but specifically by the S classification. Progressive elevations of AFP, beta-HCG, and LDH push the patient into the S1 through S3 categories, which heavily dictates the systemic chemotherapy they're going to need later on.
Finally, let's wrap things up with Section 5, Golden Bedside Pearls. Okay, before we finish this explainer, let's lock in some of these golden bedside pearls. These are the rules that separate the novices from the experts, and frankly, they will protect your patients and your medical license. This right here is the absolute paramount rule of urology. Never, ever perform a needle biopsy or a transscrotal incision on a suspected testicular tumor. Why? Because the testicle descends from the abdomen during development, its lymphatic drainage naturally flows all the way back up to the retroperitoneal nodes. If you pierce the scrotal skin with a biopsy needle, you just contaminated the superficial inguinal nodes. You've literally altered the lymphatic drainage and completely upstaged the patient's cancer. Always use a radical inguinal approach. Here's a fantastic trick for those of you rotating through pediatrics. If a kid presents with acute scrotal pain, look very carefully at the upper pole of the scrotum. If you see a distinct blue discoloration shining through, the classic blue dot sign, you're looking at ischemic necrosis of the appendix testis. It's just a twisted vestigial remnant. The great news? It's a benign condition that does not require the OR. You can confidently treat this conservatively with NSAIDs and bed rest.
Also, make sure you remember this structural difference when you're evaluating a hydrocele. In infants, hydroceles are almost always communicating because the processus vaginalis is still patent, letting fluid travel directly from the abdomen down into the scrotum. That requires a high ligation up in the groin. But adult hydroceles, those are non-communicating.
They just arise from a simple, localized imbalance of fluid secretion and absorption in the sac itself, so they only require a localized scrotal excision.
And that brings us to our final thought for today. The acute scrotum is easily one of the highest stakes presentations you're ever going to face on the ward. Every single minute of ischemia counts. So the next time you're on call and you're looking at a patient in the OPD with sudden, exquisite pain and an absent cremasteric reflex, are you going to confidently trust the clinical exam steps we just built today, or are you going to risk a testicle by falling into the imaging trap? Learn the anatomy, trust your physical exam, and act decisively. Thanks for joining me on this explainer. See you next time.